time to welcome our speaker, Dr. Sara Watson. She's a pediatric endocrinologist at the Wendy Novak Diabetes Institute and Norton Children's Endocrinology. She currently holds the Jack Henderson Chair, Endowed Chair of Pediatric Endocrinology for the University of Louisville. She leads the program for children with type 2 diabetes and developed the Healthy Weight and Wellness Program to treat childhood obesity. Dr. Watson continues to be involved in multiple research studies aimed at improving outcomes for children with diabetes. So she is going to talk to us about management of obesity in adolescent patients. Welcome, Dr. Watson. I'll turn it over to you.
Thank you very much. So thank you everybody for joining today. We're going to start just the housekeeping things. I think on the slides before it mentioned that I do have I do participate in clinical research with different sponsors, but I don't receive any money from that. And so they have looked at all of that, at those conflicts. I wanted to go through a few things today. I wanted to discuss the current guidelines for management of obesity in pediatrics and also talk about pharmacotherapy for the treatment of obesity. And this is a topic that we've talked a lot about over the last few years. You know, a couple of years ago now, the AAP released their first set of guidelines for the management of pediatric obesity. And I think that really changed the conversation that we have around this topic. So I don't want to revisit the same things that we've talked about the last couple of years, but really try to focus in on where we are right now and how we are implementing these new guidelines and the latest updates really in practice with our patients. So I thought it'd be really important to start with what's changed and what really hasn't changed. So what hasn't changed are the statistics on obesity. We don't have any new numbers in the last couple of years. All of this data is from 2022 to 2023. And so Kentucky still ranks very poorly as far as the rates of obesity across the age groups. And I think that we see this in our clinical practice on a daily basis, where the majority of our patients will come in having some concern or at least needing for us to address overweight or obesity. And we're treating this as a chronic disease, and the approach to that is really to build on relationships with families where we have a shared decision making as far as what their needs are and how they want to address treatment for overweight or obesity at that time. And those needs are going to change over time as kids get older, as treatment options change as well. So it is something that's really important that we go back to as we see patients at all of their well child visits or when they show up for other concerns. The lifestyle changes remain the foundation for treatment. And we know there's been a lot of work on what diets should we recommend. There have been studies that have looked at specific diets. Some of the intermittent fasting, which usually is referred to as time-limited eating. There have been newer studies in pediatric patients with regards to that. There have been studies using plant-based diets and other very specific recommendations. Right now, we haven't changed our overall recommendations to patients because there really isn't a good body of literature to support one diet over another. It needs to be tailored to the individual families and what they're comfortable with and what they are wanting to move towards. So there are some specific limitations with trying to implement any kind of intermittent fasting in a pediatric population because so much of their time is related to school and travel to and from school, which makes their meal times very set and not really flexible in the same way that we have in many of our adult patients. So the very specific strategies we don't recommend as far as that goes, but we do have discussions around diet changes with all of our families. There are still really great resources as far as meal composition with myplate.gov. They haven't really changed and they're available in Spanish too. So that's been a great resource for us to use. And then we kind of target one specific topic at a time. There has been work done by the U.S. Preventive Services Task Force quite a few years ago now that I think we're all familiar with that says we really need to do these intensive lifestyle modification programs, and you need at least 26 contact hours to have the best effect if lifestyle changes are going to really change weight in the long term. We are not able to implement that in primary care practices. It's just not feasible. And so right now, there are not community programs that are available covered by insurance for us to make referrals to. So we are not focused on structured programs in quite that way, but we do include lifestyle counseling in all of our visits and just in a targeted way for the families. Physical activity is part of that, as I mentioned. And I do think that our discussions around physical activity have evolved a little bit over the last couple of years. We know that children, when they're very young, before adolescence, they typically are pretty active in just general play, and they don't have to be as intentional about making sure that physical activity and exercise are built into their day. When we ask patients about their engagement with physical activity, I'm sure many of you hear the same answers that we do. I walk a lot at school, and just between classes and things like that. And so I do think that our counseling has evolved to try to and point out that those activities count. We are going to include that as physical activity because that's just any movement where you're using those large muscles in the body. But exercise is that subset, which is planned, structured, and it's really done it with an intention of improving physical fitness. And we need to include all of those different types of movement in our days. I have a little bit different discussion with patients when they do have glucose metabolism problems. And that's, a lot of our patients have prediabetes or type 2 diabetes. And physical activity can be really helpful specific to that treatment, but also as patients are developing insulin resistance. And so I do think it's relevant to a broader group of patients with obesity. When you are physically active, we stimulate an increase in glucose uptake into the muscles. And initially, that really relies on carbohydrates as the intensity increases. But we are going to stimulate blood glucose uptake that is not dependent on insulin. And so when you are dealing with patients who do have insulin resistance or on that pathway towards type 2 diabetes, physical activity kind of overcomes some of those barriers and can be really important in maintaining overall health. So we do talk about, for exercise, we need activities that are both moderate or vigorous intensity. And in general, those are things where your heart's beating faster and you're working up a sweat. But giving people very specific recommendations that they can do is often helpful. I've had patients ask, will my insurance cover a YMCA membership? And there are limitations as far as the resources to participate in really structured activities. And so being able to have just a few ideas where you can do things that aren't going to require specific equipment at home, using our body weight for resistance and strength training with things that are classic exercises like push-ups and pull-ups and getting more intentional when we're choosing exercise videos and those types of things that I'm sure you're recommending for patients as well. Bariatric surgery is not the focus of our discussion today, but it's still on the table. And that question does come up as we have newer medications to treat patients. The role of bariatric surgery is still there. We have a large patient population who's eligible. We do not, and these are, as far as the recommendations for who's eligible, typically it's 13 and older with severe obesity and some comorbidities, or if you have class 3 obesity, where that BMI is at the 140th of the 95th percentile, which we now have better access to those extended BMI growth charts. And so it's much easier to identify those patients. We don't have local bariatric surgeons who are taking care of our adolescent patients. So we do have to refer them, and then they have to be able to do that travel. But we do still have patients that this is a good fit for. We also haven't addressed a lot of underlying problems that are contributing to obesity that are outside of what we can control or address in a clinic visit. But I think it's important that we have these things and put these in context, right? So we know that there is a link towards poverty as far as an increased risk of obesity and comorbidities from obesity. Education is associated, lower educational attainment is associated with a higher risk of obesity as well. And just neighborhood design and housing locations. Do you have access to places where you can send your kids outside to play in a safe neighborhood? And then access to treatment. And we will talk more about access to treatment, but those things are still ongoing. But what has really changed is the conversation in the media, on social media, and just in our patients' families. And I think a lot of that conversation around the newer medications are driven by the newer medications and increased access to those has meant that we are addressing the pharmacotherapy and other treatment options for our patients in our clinic visits at a much higher rate. So our conversations around obesity in the clinic are certainly changing because of that. And it's affecting what we're doing in primary care as well as in subspecialty care as well. We have seen across the board increase in the incidence of comorbidities from obesity. That hasn't changed. And the recommendations are still there that primary care is evaluating children starting at the age of 2 who have overweight and obesity for obesity-related comorbidities. And the age that you start screening for those certain comorbidities changes. We're not screening for type 2 diabetes at the age of 2, but in that age-appropriate way. We are doing more genetic testing for obesity. And as we see this increase in obesity in our patients, and excess calories drives a lot of that. So I just wanted to mention those instances where we may have different treatment options, and really doing genetic testing is going to be of great benefit to our patients, so that we are still keeping a lookout for those things as they come up. So these different conditions, Bardet-Biedl syndrome, and then genetic mutations that are in that melanocortin-4 receptor pathway do have different treatment options, and we will see those in clinic. So I want to review them just quickly. So they are going to show up with other signs and also with early onset obesity for all of these. So the recommendation for testing for Bardet-Biedl syndrome, you have primary criteria and secondary criteria. So if you have 4 primary criteria or 3 primary and at least 2 of the secondary criteria, that's when the recommendation for genetic testing comes in. And I think many of us are probably familiar with these things, but those primary criteria are retinal degeneration, polydactyly, central obesity, learning disabilities, kidney malformation, and then hypogonadism or genital abnormalities. And I think that typically when I've seen this, there is vision impairment that is pretty early onset, and obesity is pretty early onset as well. The other genetic mutations in that pathway are the POMC deficiency, where you have a normal birth weight, but you have early onset obesity in the first year or 2 of life, and it is driven by hyperphagia. And then you also have adrenal insufficiency, and this one is the one that's associated with that pale skin and light or red hair. And then the LEPR deficiency, you also have early onset obesity prior to the age of 1 with hyperphagia, and then hypogonadotropic hypogonadism. The PCSK1 deficiency also has some digestive issues. So you have diarrhea, digestive problems, slow growth, and then the same pattern of that early onset obesity with hyperphagia. And then they tend to have pituitary hormone deficiencies as well. And I'm bringing up this pathway, not because I want to beat on pathophysiology, but because there is specific treatment for this, and it just kind of explains how we're treating these patients. So I'm not going to belabor this, but all 4 of those conditions, the impact is in this particular pathway. So with the Bardet-Biedl syndrome, you have a defect in the leptin receptor, making it to the cell membrane of the POMC neuron. And then with the other, you have a defect in the activation of that neuron to trigger the MCR4 neuron. And this pathway is linked to satiety, which is why they all present with hyperphagia. So if you have any of these genetic defects, the ultimate result is that you're going to have hyperphagia and obesity. And so there is a specific medication that stimulates the MCR4 neuron, and it effectively normalizes the endpoint of satiety for these patients and addresses obesity. So this is one of those great examples where we were able to take the genetic defect and develop a medication that addresses that particular defect. And we do also have different treatment for Prader-Willi syndrome. And this group does not have early onset obesity. Instead, they typically have failure to thrive in childhood, and then the hyperphagia doesn't develop until closer to the age of 6, and with obesity after that time. And then, of course, our treatment is growth hormone as well. We know that there is a large number of genes that are related to obesity in our patients. So GWAS studies have identified over 300 loci. So I've just mentioned 5 that we can treat with something other than our lifestyle modifications or the general pharmacotherapy that we have. But the hope is that as we do learn more, we'll be able to target some of these other genetic mutations and come up with more specific treatments for our patients with obesity. So all that to say is genetics is a huge driver of obesity, even outside of those very specific causes. But testing and the benefits are really going to grow as we learn more and go forward. So these are our general pharmacotherapy treatment options outside of that. And the recommendation is that we can start at the age of 12 and older, and that we should be offering weight loss pharmacotherapy as an adjunct to those foundational pieces of diet and physical activity and exercise. Most of our medications are approved for 12 and up. So this is a list of the medications or classes of medications that are approved for the treatment of obesity in adolescents. Phentermine is only approved for 17 and up at this point, but it is used off-label in younger patients, and it is inexpensive enough that off-label use is possible. But all of them are going to be for people who are in the obese category, so a BMI percentile of the 95th or higher. And you can see there are some contraindications to use. So phentermine is sympathomimetic, and so we have uncontrolled hypertension, and we also pregnancy. None of these are recommended for use in pregnancy, and so birth control is something that we talk about with all of our patients when we're using these medications as well. We'll talk about orlistat some, but it does affect absorption, so malabsorption is a contraindication. And GLP-1 agonists have a black box warning for medullary thyroid carcinoma, which was seen in rodent models and has not been seen in humans, but has been seen in rodent models. So that is something that we need to talk about with our families as well. So I want to talk through some of the practical pieces about how we select treatment for patients and also how we talk with, counsel them about making the choices for which ones we're going to be able to use. One of the big questions that everyone has is, well, how much weight am I going to lose? And we know from looking at these studies, some people respond really well to any number of these treatments, right? And some people don't have weight loss. And that is kind of universal for any of these that we use. So we'll look at that mean change in their BMI percent as the best way to compare the effectiveness of these studies right now. So phentermine alone, there's very little data in adolescent populations, but in studies that have been that are available, there is a mean change in BMI of about 4.1% after 6 months of treatment. It's only approved in that 17 and older age group for short-term treatment of 3 months or less. And the reason is because of concern for adverse effects, primarily with pulmonary hypertension and tachycardia. And then there's also a list of symptoms that if they develop, we should stop the medication. And that's going to be dyspnea, angina, syncope, or lower extremity edema. Phentermine is also a controlled substance, so it does require a DEA license to prescribe. And then orlistat, which we don't use as often, but the mean change in the pediatric studies was about 0.5% in the BMI after 12 months of treatment. And the primary adverse effects are going to be oily diarrhea and spotting, and it's because it blocks the absorption of fats. So the recommendation when you use this medication is that you need to really limit the calories from fat to less than 30%. And that's to help mitigate those side effects. Because it blocks absorption of the fat-soluble vitamins, you also should take a multivitamin with it. And we need to, with all of these medications, we need to look at drug interactions because it can also affect absorption of other medications. So something we need to be familiar with. A lot of the talk has been about the GLP-1 agonist, and we do have a couple of those that are approved for weight loss in pediatric patients. And I think that this slide, I think is more interesting because in this study, they used orlistat as a comparison. And so I'll just point out that they did have more weight loss in this population using orlistat than what I just reported in that other study. But this was a study looking at the effect of these different doses of liraglutide. And as you can tell, the higher dose, you had better weight loss. And so that's what they ended up using for the studies. And this is pediatric data. And I want to talk about the effect of the liraglutide in pediatric patients. But first, I want to kind of orient you to these waterfall plots because they're really, I think, helpful to look at, but not something that I've shown yet today. So for those who might not be familiar with them, this is going to show the change in BMI over time for the participants. And each participant is represented as a bar on this graph. So you can tell it goes from the highest percent change in BMI all the way to where you have this inflection point and the bars start sticking up. Those are patients who gained weight while they were on this treatment. Now, the FDA, when they evaluate these studies, and what we have decided as a whole is that to be approved for use for weight loss, you need to achieve at least that 5% reduction in BMI. That's what we have decided is a meaningful change in weight. And that's that kind of orange colored dotted line that you can see. And in the pediatric study, we treated for 56 weeks, and then, of course, they stopped treatment. So this shows how much weight loss they had after 56 weeks. And in that time, 43%, so I mean, almost half, lost at least 5% of their BMI, which is great to have that reduction. But also a quarter had at least a 10% reduction in their BMI from baseline. And that's compared to placebo. So even on placebo, almost 20% had at least a 5% reduction in their BMI. And I will mention that in all of these studies, everyone, even the placebo group, gets the standard of care lifestyle interventions. So the difference here was really just the medication, and everyone had lifestyle treatment. That was whatever the study site standard of care was. So it wasn't necessarily a high intensive program, but it's just standard of care. So that's pretty good. The mean, so the kind of how much the average was a change of 6.2 reduction in BMI percent, which is what we can share with our families. The semaglutide, which is another GLP-1 agonist, there are a couple of things you can tell just looking at this waterfall plot, and that is that there are fewer bars sticking up above the line. So you had a larger percent of patients who had weight loss over the treatment time. Now, this is 68 weeks of treatment, so a little bit longer, but 76% of the participants in this study achieved at least a 5% reduction in their BMI, which is pretty significant. But when you go down, the exciting part about this is not only are we reporting how many lost 10% of their body weight, which was over half, we're also reporting how many had a 10% in body weight, 10% reduction in BMI. But we're also reporting how many had a 15 and 20% reduction in BMI. So on the semaglutide, 40% of the study participants had at least a 20% reduction in their BMI, which is really significant. And comparable to kind of the 5% reduction that we saw with some of the medications we've already seen. So it is more effective. Now, the mean percent change for this particular study was 16% overall. I'm going to mention tirzepatide. It's approved for 18 and up, and they're doing studies in adolescents right now. The studies are still enrolling, but the expectation is that study is going to wrap up soon. So this is kind of what we can expect to hear about next, I think, in pediatric patients is going to be this medication, which builds on that GLP-1 agonist by also adding a GIP agonist. So this is a dual agonist. This data is adult data, but I just want to give you a flavor for what to expect. And in these are different doses on the first chart and that mean change in absolute body weight. But then on that second chart, you can see the percent participants in each dose, with the darker color being the higher dose. The percent of participants in each dose who did achieve that degree of weight loss. And you can see that about 32% achieved at least a 25% reduction. So it is in adults more effective than just the GLP-1 agonist in general. So we expect that as we are able to offer more treatments in pediatrics, we may see different outcomes as well. There are significant side effects with the GLP-1 agonist that, in addition to the black box warning that we talk about with families, the primary side effects are GI. So nausea, vomiting, and then abdominal pain. There's an increased risk of gastroparesis, and then also of cholecystitis and pancreatitis. So we do talk about these things with patients, we have had a few patients that have had significant side effects and they haven't been able to tolerate the medication. So the other medication that we have available is phentermine and topiramate as a combination product. And this is the data from the Adolescent study, and they treated adolescents for a year, so very comparable to the GLP-1 agonist. That's longer than the 3-month time period that I mentioned phentermine alone is approved in. And this study also goes down to the age of 12, so it has been studied in that age group. the mean weight loss, there are two doses, the top dose and the mid dose. So the mean weight loss for the mid dose was 4.8% reduction in BMI percent. And then in the higher dose, that reduction was 7.1%. So that's comparable to the liraglutide, but not as good as the semaglutide. And then also you had in the top dose, about a quarter of participants had at least a 15% reduction in BMI. So they did look at this for all of the cardiovascular adverse effects that we've been worried about. And in the study, there were very few adverse effects reported, but we do still have the concern that the topiramate is teratogenic. So we do have to be very careful about pregnancy, and it's recommended that serial pregnancy tests are monitored when patients are treated with this medication. And then there's that risk of pulmonary hypertension, tachycardia, hypertension, as I mentioned before, and then dizziness and some GI effects as well. And I just mentioned bariatric surgery to kind of put it in context as far as how good is the weight reduction from the medications compared to bariatric surgery. I think that's a really important consideration when we're looking at overall treatment recommendations for our patients. And this kind of shows the data from an adolescent cohort in blue and then adult data together. But that mean percent weight change is about 25% in the pediatric population that we see with that. So just to put it in context for our patients. After the GLP-1s have been approved, there has been a lot of discussion around an increased risk for depression and suicidal ideation. So I just want to touch on that today. You know, there are safety reviews that are underway. The European Medicines Agency, kind of our comparable, their version of the FDA, has said that they're reviewing all of the data, and they've been doing that the last couple of years. Right now, semaglutide has a warning on there, a recommendation to monitor for depression or suicidal thoughts and to discontinue if it develops. Liraglutide does not have the same warning on it. And then the phentermine and topiramate combination one also does have listed as a side effect changes in mood and increased anxiety. So right now, our approach is to screen for depression and suicidal ideation. You know, this population is at a higher risk because of obesity and chronic disease, where we do see a higher risk of depression as well. So I think it's helpful in general for our patients to just be aware of that. And then I do counsel patients that there may be some increased risk, but there isn't any more specific data, though there are some really interesting articles published just looking at how it's been reported on social media and the media in general, how it's picked it up and people's thoughts on that. But as far as reviews and of the safety data reporting, this is kind of what we know. The barriers to getting patients access to these pharmacotherapies are really not changed yet. Insurance coverage remains the largest barrier. Indiana Medicaid and Kentucky Medicaid do not cover any weight loss medications. I didn't know as much about how these things get approved until these particular categories of drugs came out. But essentially, weight loss drugs as a class have to be added to Medicaid by the state legislature before they can be covered on those policies. So that advocacy has been ongoing. There was some thought that we were making headway in that area because those medications were to be added to Medicare. And you know, we've all heard the mantra of, well, what happens with Medicare will eventually follow with Medicaid. But that's been held recently. And so it's an open question that hopefully will improve over time. But even for our private insurers, the model for how this is covered is unique in that it's left to the individual employers. So it is not possible to say, oh, you have Anthem insurance and then this is going to be covered. Most of the companies that are selling these medications will have links on their website where you can look up your particular policy and find out if it's covered. Or we recommend families talk to their HR department and find out if particular medicines are covered. Sometimes they cover the weight loss medications as a category, and other times employers will pick a certain one and as a preferred medication. So that changes over time. And so it's a little bit hard to keep up with for families, but having them aware that this is a really unique situation and to really work with us to kind of stay on top of when there are changes can really help because there's a big burden for prior authorizations as well. Licensing for the medications that control phentermine or include phentermine is important since a DEA license is required for that. So that's for phentermine alone as well as the combination product. And then these are newer medications. And so we do have to do things like the CME and kind of hope we build some comfort for prescribing these medications. The injections for the GLP-1 agonist is also something that we need to be able to counsel patients on. And they are available in a pen device, but they are starting to be available as a vial as well. And I want to mention that because a lot of patients who are taking these medications are paying out of pocket. And so I do have conversations with families often about how much does this cost if my insurance doesn't cover it and I still really want to use these medicines to help. There are coupons available. So on goodrx.com is a common place I'm sure many people are familiar with. And the price of phentermine varies depending on which pharmacy you go to. The cheapest one is Publix, which we actually have one now locally, I think. So, but most of them is $15 to $20 a month. That's in line with what a copay typically is. So it is the most affordable of these medications for families who do have to pay out of pocket. The rest of these patient assistance programs are through the manufacturers. So the phentermine and Topamax is a brand name of Qsymia. And so the program is called Qsymia Engage. And I will, it's a different price depending on if you want to use a home delivery pharmacy or the goodrx.com, which you can get a coupon for a retail pharmacy. If we want to use the home delivery pharmacy, it's Medvantix, and that was determined by the Qsymia Engage program, not by us. But the cost is least going through that pathway, so it's about $100 a month. And to prescribe that in Epic, to send it there, it's going to be searching under the pharmacy name when you prescribe Qsymia and sending it to the Medvantix pharmacy. Also, the families can get a coupon on goodrx.com and pick it up at a retail pharmacy, and then that's about $150 a month. The tirzepatide right now, for if we do have patients that are 18 and over, they will, there's a program through Lilly Direct that so that's manufactured by Lilly. And instead of giving the pens like you get from a retail pharmacy, they will send a vial and syringe to families. And then to prescribe that, you search for the medication name of Lilly Direct is how the medication name starts. So that's what you have to search for when you're searching for the drug name. And then it'll have that dash tirzepatide. So I mentioned that because it is a little bit different. And the single dose vial for the lowest dose is $350, and then it jumps to about $500 a month after that. And then the semaglutide, which is the brand name of Wegovy for weight loss, that one is manufactured by Novo Nordisk. So their program is called NovoCare. It's about $500 a month, regardless of the dose. And in Epic, you can prescribe the semaglutide under the name Wegovy. So it will have that in the parentheses because that's also called Ozempic, but that is not approved for weight loss in pediatric patients. And then you need to send it to the pharmacy name of NovoCare. Um, just as a practical tip to making this work. So the key things to take away are really that we still have to counsel families that diet and physical activity are foundational to treatment and also to prevention of comorbidities and long-term weight loss. A lot of the mantra around these using these medications has been we're going to use it as long as it is effective. And I don't disagree with that at all. But what we found in practical use essentially is that we can't always guarantee that families are going to have access to these treatments for as long as they may benefit from them. So we really want to set them up for success in the long term. And that is going to be that strong foundation of healthy diet and being physically active and participating in some moderate and high intensity exercises. All right, so we do have a healthy weight and wellness program that we're starting, and it's built on the expertise of our entire team. So I work with a lot of really great people, and I just want to make sure that I mention all of their efforts in supporting our work in endocrinology and thank them for all of their help as we try and do the best we can for our patients. So I just want to open this up to any questions. I'm trying to see, if I
Yep,
can
I can read them to you.
oh, thanks. I should
So
be able to
that's okay.
find them.
Everyone will want to know them too.
Okay.
Is there any discussion or plans for having group nutrition counseling and outreach for families that can be done in a group setting throughout the city, since we are so dietitian limited for individual appointments within our community?
That's a great question. So the answer is yes. We have looked at that in the past, and we've actually done some group nutrition classes in our clinic in the past. And it's had some mixed results. So as far as families that are excited to participate, so it's a great option for a very specifically selected group of families. And so we are looking at that, but I think first we're going to put together, or what we're working on building first is going to be some education that's available on the internet where they don't have to commit to being in a certain place at a certain time, but we can still provide that expertise. So that's what we're going to work on building first.
Okay. And then can you explain how we should be diagnosing obesity in terms of ICD-10 coding? Epic has recently taken off BMI greater than 95th percentile in pediatric patient, kind of in quotes, and as an option. And all the current options that remain use the word obesity. Words we use when talking to patients do have an impact. Should we say increased weight for length or overweight?
That's a really great question. I typically say higher weight. And I got that from patients, from a, focus, well, I shouldn't say focus group, but patient advisory committee that's helping me put together research projects in this area, to be honest with you. So you're correct that that language can be very stigmatizing, and we want to be sure that we have that conversation in a way that we're engaging families and not putting them off, making them not want to come to visits. Sometimes I also ask families if they want me, when we're seeing them back and talking about weight change, I ask if they want me to talk to them about specific numbers. Sometimes they don't want to know. I weigh this much in pounds, so I do ask. Most people say, yes, tell me the numbers, but some don't. And we want to be sure that we're uh, being sensitive to that as well. The ICD-10 codes, I noticed that they changed, and it's been a little bit of a struggle for me because they do have selections that are based on those extended BMI categories. But the extended BMI categories are not on the side panel when I'm entering my charges. And so I have to pay attention to what those are before I go to put my charges in so that I get it correct. But otherwise, the question that I always ask myself is, if I use a general obesity ICD-10 code, I don't know what it changes in the downstream versus using the more specific codes. It will change as far as if I want to go back and find patients who may be eligible for things as newer treatments come up and things like that. So I do try and include that, but if we're in a situation where we can't, then I think having that, there's still a general obesity without comorbidities versus obesity with specific comorbidities that I think is okay to use
Okay.
until the billing people tell me otherwise.
Right. Could you comment on the use of metformin for weight gain associated with antipsychotic or mood stabilizer medications?
Yeah, that's a good question. There has been some use of metformin, off-label use of metformin, for weight loss, and there is very limited data as far as the use in that specific instance that you have brought up. So right now, there's not a broad recommendation to do that. The idea is that it addresses the underlying insulin resistance. But there hasn't been any study that show that it's really beneficial. Metformin, we see a lot of patients who can't tolerate metformin because of GI side effects. And so I typically do not recommend it. But that could change as we get more data going forward.
And then are there any plans or to lobby Medicaid for including weight loss medications?
Yes, and it started in the session in 2023. So there has been significant lobbying, and the Medicaid, the medical director is the conversations we've had with people on the Medicaid side are very positive, and there are a lot of benefits to preventing chronic disease by starting treatment for obesity in childhood. So it is really at the level of the state legislature, and you know, I will mention to families that that's the pathway. We have to wait for them to change. And part of that is because there's a growing frustration with why can't you just do a prior, like do a oh, now the words are leaving me, but contest it when they say they're not going to cover it and appeal. Thank you. An appeal for this and get it covered for me. And so that is a conversation that when we're having those with families to say we can't appeal this. If it is a category exclusion, if we're not covering any weight loss medications, there isn't an appeal that will work. And that's a lot of labor that we need to save on our clinic staff by not doing that. And so I think it's important that we kind of let people know that this is out of our hands. It's not our health system that's not on board with taking care of them. It's not our people. It's just a system issue.
All right. What are ways that you address and encourage positive relationships with food during visits? And do you have any resources for this?
That's a really good question. So we do recommend counseling and establishing with a counselor or therapist. We have some greater access to the licensed clinical social workers at the Novak Center in the last couple of years that has just been invaluable to help patients with a variety of health problems, and including binge eating and how they address or that specific relationship with food. So that's typically the path that we take. It's just if they identify that there's a harm in that relationship right now, some people will come and say, I know I'm eating because I'm bored or because I'm stressed or because, these other things, then we recommend that for long-term care.
Okay. Is the bread and butter GLP-1 medication for pediatricians going to be Wegovy since it's for 12 plus year olds? Should we get comfortable prescribing this independent of a specialist? Should administration be given in our clinics or at home? And should we send these patients to endocrinology first and let you get them started and then take over?
That's a great question. I think eventually it's going to be primary care that will be prescribing this and starting the patients on it and following them. I think it started as a home with endocrinology because we use these medications for diabetes. And so we already had a comfort level and familiarity with them. It is an injection that is given once a week with a very small needle that we use, the same sub-Q needle we use for insulin. And so patients give it themselves or their parents give it. We do train them and, show them on a test device in our clinic. I know in the adult world, they don't do that with diabetes medicines either. They, pick it up. And a lot of them, there are videos on the manufacturer's websites about how to give it and things like that that can be a resource to help with the training. I think that the semaglutide is the most effective. So if all things being equal, if insurance is going to cover it or families can afford it, then that often is where I start. And so right now there isn't a bread and butter just because of access issues, and we go with what people have access to or what they can afford. But if all things being equal, that is, yes, where I start. And we are happy to start it with families and let the primary care doctors follow it if they're comfortable doing that. But I think it is not outside the purview of the primary care doctors to take this on as well.
All right. And is the endocrinology clinic you mentioned at the end of your talk Healthy for Life 2.0?
Gosh, I haven't thought of it that way, but I guess you could think of it that way.
Good. All right. All right. That's all the questions we have. Thank you, everyone. Thank you, Dr. Watson. And thanks, everyone, for joining us today.